unmuting. Thank you, Jeremy. And what Jeremy didn't say was I had the pleasure of being able to work with him when he was working over at the Center for Child and Family Health. So I'm always happy to join you and join the Governor's Institute. I am going ahead and sharing my PowerPoint, just getting confirmation from folks that you can see this.
Everything looks good. Video and audio is great.
Perfect, perfect. Well, that's good because if you all can tell, I'm in a pretty empty apartment because I just moved. But thank you for the wonderful introduction. It is always a joy to be in this group. And I just want to acknowledge and name that there is more expertise in this room, in this space, than I can even fully appreciate. So I know we don't have the chat on, but I want to encourage you all to share via the Q&A. I saw how that worked in the talk before mine. And being able to share resources, I always learn a lot when I join this group. So like Jeremy said, we're going to really talk about taking a wider lens to substance use in teens and looking at the relation between suicidality, trauma, and other related factors. So taking a very close look at comorbidity as well. Um, Jeremy, I'm going to ask you really quick too. Do I need to monitor the Q&A or?
We will do that for you so you
Okay.
can focus on your
Thank you.
presentation. We'll
I
get
saw
back
some
to
action there and I just didn't want to ignore.
that.
All right. So I want to give some acknowledgments and gratitude to the folks that I work alongside. As Jeremy said, I am a clinical psychologist, so I still work alongside youth, families, adults that really experience trauma, and that's where my specialty lies. I also work in the CAST clinic over at Duke, which is the Center for Adolescent and Young Adult Substance Use Treatment and Prevention. I work alongside Paul Nagy, of those of you who know him, and have had a lot of great experiences there. I also work with the National Child Traumatic Stress Network, which is a national network of providers, centers, agencies across the US that really focus on trauma-informed treatment for children, youth, and families. And I also work with the Trauma-Informed Communities Projects here in North Carolina, where we focus a lot on social justice work for those most impacted in the state of North Carolina. We're a lot of different lenses, but really thinking from an individual, community, state, and national lens is where my work lies. So today, what I'd like to do is review some recent data. And it sounds like you all have reviewed a lot of recent data. I actually learned about some new databases just from joining the previous talk, which I'm excited about. Then we're going to go into discussing common comorbidities and co-occurring factors, knowing that it cannot be all-inclusive, but we'll try our best. We'll review some trauma-informed approaches, integrated treatment and tools, and identify some key factors in mental health approaches and access to and components of treatment. I want you all to start, though, of just, giving yourself space and being a trauma-informed provider. I like to try to live those values. So whatever you all need to do to stretch or ground yourself or get a drink of water, or I don't know if you eat lunch at 11, but eat lunch. Just orienting ourselves and acknowledging that this topic can be heavy and we all carry our own lived experience and stories, and acknowledging ourselves as full people as we move into this space together today. Okay. So talking about some recent trends, and I'm really looking more at a national level. There's a little bit of data in here from North Carolina, but from a national level, I don't know if you already have reviewed the Youth Risk Behavior Survey, which is from the Youth Risk Behavior Surveillance Survey Program at the CDC. So this is a anonymous survey to high school students given every 2 years. And I don't know if you all remember in high school getting that survey where it has a bunch of questions about risk behavior, about now it has more questions about mental health. There's questions about wearing your seatbelt, about substance use, but it's given across all 50 states in private and public schools. So it's really getting an insight into what our high schoolers are saying, at least as much as you can in a survey. So this is a survey of nationally representative sample of US high schoolers given every 2 years. And this is the latest data from 2023. And if you can take a look, I love this screenshot because it gives you a pretty quick look at what the trends are saying. And these trends go from 2013 to 2023. And you can see that, at least nationally, that in these trends right here in the green in the very far end, the one right before the 2 year change, that trend is looking like things are going in the right direction if we're looking at trends from 2013 to 2023 nationally. So those who currently drink alcohol, use marijuana, ever use select illicit drugs, we're seeing those things trend in the right direction, meaning the rates being reported are going down. And I want you all to really think about why that is, what can contribute to those rates going down. And there's also what's also interesting here is the 2 year change. So they look at the most recent change, yellow meaning that it's pretty much stayed the same, not a significant difference. Green meaning it's moving in the right direction. So we're seeing some improvements based on these reports nationally. So then I looked at another national level survey, which is Monitoring the Future survey, done by NIDA and the University of Michigan. And this is an insight or a survey for the 8th, 10th, and 12th graders. And also confirming, at least this is one snapshot. So I have links in here for you all to go and take a look at the data yourselves because there's dashboards and ways that you can look at the data. But this is just one example of it, just looking at trends over the last 12 months that youth are reporting any kind of illicit drug use. And one of the things that I like to lift here is Dr. Nora Valco's quote, looking at these steady and declining rates, and they continue since COVID-19. The reason I highlighted that is because one of the things that she was lifting during the pandemic was we're seeing a decrease in substance use reported as well as we can get the data. So she says this trend in the reduction of substance use among teenagers is unprecedented, that we must continue to investigate factors that have contributed to this lowered risk of substance use to tailor interventions to support the continuation of this trend. So I want you all to continue thinking about that and what could contribute to that trend. Some of the things, and I will say, since we don't have chat on, some of the things that come to mind that I've had discussions in spaces with other providers is first, like how accurate are the reports of, anonymous surveys given in a school, we get the best that we can, but also how inclusive are these reports to the ever-changing substances that are being used. So things like kratom, things like Delta 8, and are those being measured? So thinking about, are we changing the questions to fit the ever-changing landscape? Because I know as a clinician, I'm learning new things all the time from my youth about what is being used and what people can get now in smoke shops and other things like that. The other thing that's important to look at is our data in North Carolina. And this is a trend kind of in the opposite direction, right? So what about North Carolina? And this is looking at youth and young adult opioid OD deaths from Kaiser Family Foundation. So they do, with the National Vital System statistics, they look at death rates over the course of time. And this is for 0 to 24-year-olds. But I did hear the question before about disaggregation. We're going to get into that in a second. There are ways to look at this data in a number of different ways to look at those most impacted. And so from 1999 to 2022, what we're seeing is the rate of opioid OD deaths for youth and young adults growing. So really making sure that we're looking at that as well. And I learned about the TOPS database, so I'm going to look into that after this presentation too. Okay. So also looking at rates of suicide in youth. So we're looking at the co-occurrence, but right now we're looking at it separately. We'll talk about the co-occurrence in a second. And we know that for a long time, this rates of suicide in youth, it has been the second leading cause of death for our nation's youth. Second and third, it hovers between those two. On this slide on the left side, you will see the age range at the top of the grid. And in green, you'll see the suicide rate for our nation's youth. And this is from 2023. It's from the CDC. There is a database called WISCARS, WISQARS. And you can take a look at that on your own and even disaggregate this data to look at different trends, disproportionalities, disparities, to look at how these rates change over time. And you can see here that the suicide is the second leading cause of death for 10 to 14 and 15 to 24-year-olds. In 2022, it was the third leading cause of death, and it moved back up in 2023. And really, it's when I looked at the numbers themselves, it was because the homicide rate actually went down a little bit. So there's a hovering of that in between those 2 years. Some of the things to think about too, when we're thinking about rates of suicide, is that there's higher rates in males compared to females, that we know that there's higher rate of death compared to females for males, and there's higher rates of suicidal thoughts and behaviors, though, for females compared to males. When we're thinking of safety planning, we also think of most common methods of suicide, death, and we know that for younger folks, 10 to 14 years old, we think about suffocation, and firearms are the leading common method for 15 and up going forward. So when we're thinking about safety planning and how this coincides with substance use, when we're talking about lowered inhibition and if suicidality is a presenting concern, that one of the things that we have to think about is safety planning for substances, but also safety planning for these other things as well. Thinking about firearms, asking about those things, because we know that substance use and suicidality can co-occur. And we'll talk more about that in a second. Okay, so same YRBSS data, and this time looking at it through a lens of what our high schoolers are saying about suicidal thoughts and behaviors. And this again is from the latest data from 2023. And taking a look at what our high schoolers are saying is that for suicidal thoughts and behaviors and other mental health concerns, you can see the trends look a little different here. That we see that the percentages of high schoolers who are saying they experience persistent feelings of sadness or hopelessness, poor mental health in the past 30 days, and then thinking about seriously considering making a plan, attempting, so you can see degrees of severity kind of growing in that wording, and even were injured by a suicide attempt, that we see those rates are going in the wrong direction when we're thinking about trends from 2013 to 2023. If we're looking at the 2-year change, we're seeing a little bit of an improvement, but mainly things staying the same. Trend from 2013 to 2023, we're seeing these things go in the wrong direction, meaning more kids are experiencing and youth are experiencing feelings of persistent sadness or hopelessness, even having considered attempts or even attempting or making a plan to. Okay. One of the questions you all asked beforehand was about the disparity rates, the importance of disaggregating data. I couldn't agree more. You know, sometimes we'll get this message on rates in headlines, and it can be confusing. And it's important to look at and disaggregate that data to make sure we're looking for disparities and disproportionalities that do exist. Sometimes we stop here at the overall trends, and there's so much more to learn. And I will say the WISCARS data and the Kaiser Family Foundation data It's of course limited, it's not perfect, but there's ways to break apart the data to look at who is most impacted, and who has the highest rates, and looking at those trends over time. So in the name of time, I couldn't break it out in every single way, but the YRBSS, which you have a link down here to the data summary and trends report, they highlighted a couple things when we're looking at substance use. So we'll take a look at substance use, and then we'll also take a look at suicidal thoughts and behaviors and those most impacted. So as we're taking a closer look at who is reporting substance use. We know that female students and students who identify as LGBTQIA+ were more likely than their peers to report substance use difficulties. Um, Other trends here that they highlighted was that students who identify as white still outnumber other racial groups in using alcohol over the past 30 days. From 2021 to 2023, the reported rate of drinking alcohol increased for students who identify as Black. And then we also saw the decrease to that trend nationally that we're seeing, that decrease in reported rate of youth who ever used select illicit drugs or currently misuse prescription opioids, for those who identified as Black, Hispanic, and white. And that's from the YRBSS data. And I always we want to lean into our trauma-informed lens about why these rates foundationally exist, right? Of those most impacted by trauma at an individual and systemic and structural lens, and how that shows up here. And I want you all to think about that going forward here as well. Taking a closer look at suicidality or suicidal thoughts and behaviors, very similar here of those most impacted. So female and students who are in the LGBTQIA+ community were more likely to experience persistent feelings of sadness, hopelessness, poor mental health, and suicidal thoughts and behaviors. I also want to lift here that it wasn't in this survey, but it's a trend over time that I feel like does not get highlighted enough, is other populations that are most impacted by suicidal thoughts and behaviors, and I will say most impacted by structural systemic trauma. And so American Indian, Alaska Native youth have a higher rate of suicide death compared to other racial group. And that trend has been the same over time. We also know that for our Black youth and in Black communities have the fastest growing suicide rate compared to other racial groups. So that if you're looking at it in a snapshot of, in comparison from like a cohort standpoint of yearly data and not looking at it trends, it's a scary thing, because if you look at it in trends, you will see that although the rate may be lower, the trend is higher, that it's growing at a faster rate. And I, again, always want to think with our trauma lens on of those most impacted by trauma and how these things show up. There's a lot of resources out there to learn more. There is an original resource called Ringing the Alarm, and it was a call to action for Black youth suicide prevention. And I'm forgetting the name of the group that did it. But this is an extension of that original report. It's called Still Ringing the Alarm, that it's an enduring call to action for Black youth suicide prevention from Johns Hopkins and the Center for Gun Violence Solutions. There is a link here for you all to read more, and I encourage you all to do so. That there's a lot of information here to show the growing trend. I think the most recent data from 2007 to 2021, 2022, that the rate was increasing for Black youth for 144%. So striking, very striking. And the way I like to end talking about statistics is really kind of grounding ourselves in the human stories that are behind these statistics, because sometimes we can get stuck in the numbers. And one of the things that I like to center is that these are people's stories. These are someone's sisters, brothers, loved ones, partners who were lost or who are suffering from substance use, suicidal thoughts and behaviors, and they're our nation's youth. So making sure that we ground ourselves in they're more than numbers, that, and I'm in a room full of people who have probably faces that come to mind when we're thinking of these numbers or stories that we've worked alongside families and youth who have experienced these things. So I just want to take a minute to honor that as well. Okay. So looking at and going into um, the common comorbidities and co-occurring factors. And this was something that I talked to Jeremy about of like, oh, this is a big topic and oh, it's not going to be completely all inclusive, but I will try my best because we know that substance use doesn't occur in a vacuum, right? That there's a lot of common co-occurring factors. And one of the things that I advocate for, and I know you all probably feel to your bones, is the importance of integrated treatment of we absolutely do need specialization in substance use treatment, and we also need that specialization and that integrated treatment approach. And I'm seeing more and more of that. It gives me so much hope. That's the approach we take at CAST, and it does require more time. It requires more coverage. It requires more support, but it's so worth it. And why do we focus on that? So that we know, and I would say this number with my own critical thinking on the number 63%, I would say that's probably lower, just based on my own experience, that we know that the focus on comorbidities is important because the rate of comorbid substance use and mental health difficulties in teens is high. And that's not just for teens, it's for everyone. But focusing just on teens, I was trying to find a good number that we know in one study, in some research, it suggests as high as 63%, that those youth who presented with substance use difficulties, 63% of them also reported mental health difficulties. And I would say that's probably lower than what I would expect just from my own clinical and anecdotal evidence. I think it depends on what you ask, right? Like, are we asking about trauma? Are we asking about other mental health difficulties too? And that need for that integrated care. We also know that adolescence, looking at comorbidities, is a very vulnerable time, that the prefrontal cortex is developing, right? The brain is developing. Impulse control is not fully formed if you're thinking about adolescence. And I smile because I love working with teens. I have a lot of stories that come to mind when I think of my teenagers. And so that brain development is important. And you're thinking about the impact of substance use on that, the impact of decision making on that, and the need for family involvement there, of community and family involvement as guardrails to adolescence. We also know that in the teen years, that is when the emerging mental health comorbidities do show up. So if you're starting to think mid-teens, late teens, that's sometimes where we see more significant mental health difficulties coming up, and why that lens of looking at substance use and other co-occurring factors is so important. Because if we don't address both, the risk of lapse is higher. We also know there's common contributors of substance use and mental health. There's that genetic predisposition that we know about, and there's also environmental factors that we need to be asking about trauma, of things that have impacted them environmentally. And one of the things that I do clinically, and I encourage those folks that I supervise and work alongside to do, is to look at a timeline, to co-create a timeline with your teenagers of, or your adults or whoever you're working with, of when did the substance use start? And then get really curious of what was going on at that time. What was it like before? What kind of things were you feeling, thinking, doing before? What happened in your life? What happened afterwards? And then what did your substance use look like then too? Sometimes it gives that aha moment to youth, adults, families to say, oh, I can see how this is a symptom of X, Y, and Z. Sometimes, it's not the case all the time, but in the co-occurrence of trauma and substance use, that timeline is a great tool and easy to use. There's also mental health needs that can contribute to substance use risk. Untreated mental health needs, we know there's this self-medication to alleviate symptoms, and that can continue over time. without addressing kind of one of the root causes, if there is that root cause there. And we know that substance use can contribute to mental health needs, that impulse control can be impacted, and you think double whammy, right? For youth who their brain development is right there during their teenage years, and then substance use can impact that even more. We also know it can trigger an underlying predisposition of thinking the link between marijuana and psychosis, that it can trigger that earlier in youth, and those symptoms can show up faster and stronger. So these things, they can't be torn apart, right? They co-occur. These are examples of common comorbidities. Now, again, this is not an exhaustive list. It is one of them that we know: anxiety, mood, PTSD or post-traumatic stress, ADHD, conduct concerns, schizophrenia, bipolar, and other personality disorders can co-occur with substance use and often do. And making sure that, again, the case is that we're really wanting to focus on more integrated treatments of treating the substance use and the mental health difficulties that co-occur with that. We know that the co-occurrence of substance use and suicidality in teens is striking. There's a strong evidence for it. And we know that substance use is a known risk factor for later suicidal thoughts and behaviors in teens. So I'm going to give you all a minute to think about why that relation exists. Like how substance use is a known risk factor for suicidal thoughts and behaviors. And thinking about our data and those who are most impacted and those who are reporting this, our teens are reporting a high rate of feeling those suicidal thoughts and behaviors. I know we don't have chat. If we had chat, I would have you all talk about some of those reasons, but put it in the Q&A. There's that co-occurrence that exists. There's some reasons that this relation exists. I'm not saying this is all inclusive. We do know that for substance use, there's that risk of overdose, which is pretty clear. We know that there's lowered inhibitions when someone is using substances. And if that co-occurs with suicidal thoughts and behaviors, the risk is higher, right? Decision-making is impacted, which is why when you're doing safety planning, one of the first things that I do ask is like, where are the substances in the home? Are they locked away? Like, what does that look like? We think about the co-occurrence too, especially for substance use and suicide, the impact on mental health. So if folks are struggling with substance use difficulties, that can that self-medication approach, but you also still have the mental health difficulties there that are untreated and sometimes even exacerbated, and the problems can be exacerbated. Thinking about academic difficulties, family and relationship difficulties that co-occur with substance use, and that lack of treatment for the underlying mental health needs, making a case for that both and approach, right? That we're having to treat both. And again, I'm a trauma-focused provider, so I really take a look at, and I know there's a number of ways we could look at the co-occurrence of ADHD and substance use and have a whole discussion, or mood difficulties and substance use and have a similar discussion. But really, that root cause can be very similar across all those things that we know. Research evidence, it suggests a strong link also between substance use and traumatic stress symptoms. And I want you all to think too about why you think that co-occurs. And that we know not only substance use and traumatic stress symptoms, but also trauma exposure, that disproportionate exposure to inequities, oppression, so structural trauma, systemic trauma, individualized trauma. And I want you to think about how that relation coexists. One of the things that I should have said on the last slide about the co-occurrence of substance use and suicidal thoughts and behaviors is that we can't expect for people to let go of how they survive and cope without replacing them with other ways of coping, with services, with support, and addressing the root cause, right? And that could look different. The root cause could look different for every person, and addressing the root causes that are structural and systemic. I try to think from that both and approach because of how complicated substance use and the comorbidities that exist with that, and really getting curious and working alongside our youth and our families and adults to really understand the function that it serves. And we'll talk about a tool for that in a second that you all could possibly use if you choose to. We know that this relation can be complicated, right? So continued use may increase exposure to high risk situations, right? That there may be situations the risk is higher for trauma exposure, not from a victim blaming lens, but just the environment, right? We also know that integrated, I keep driving this message home, that integrated approach is essential, that treating trauma without treating the substance use can possibly increase substance use symptoms and relapse potential or lapse potential. So I talk to my clients, my patients, and those that I'm training, is that if we are pressing the gas pedal on trauma treatment without assessing substance use urges, that should be something we're consistently assessing, because if we're addressing the trauma, you're going to see, by nature of trauma treatment, you're going to see an increase in distress. And part of that is learning to cope with that and getting muscles around coping with that feeling that is not substance use. But the urge could come back. The urge could increase, that we can't do one without the other. And then treating the substance use, which may be a form of survival coping, without focusing on the trauma, you possibly increase those traumatic stress symptoms and other symptoms that could occur in that time. So it is this both and. And what that means is treatment takes longer, that there's a good period of time where stabilization and focusing solely on the substance use is needed before you can get to the trauma treatment. One of the things that I think about often is the DBT framework of priorities in mental health treatment, and it starts with life-threatening behaviors. That if there's a life-threatening level of use, that we have to address that before we can get to the trauma. So safety is always priority, and that means longer duration of treatment is sometimes needed. And then sometimes when we get to the trauma treatment, we might see a risk go up and we have to go back and attend to that safety risk first before getting into the trauma treatment. And there are integrated approaches and treatments that do exist that do a really great job at that. But I want to start first, before going into examples of those that do a really great job at that, is thinking just generally of working alongside youth and families with a trauma-informed and humility and learning mindset. That is the core before we get into any kind of program, any modality, any tool. This is the core foundation, to me at least, of how this work is done in relationship, and relationships and community are everything in this work of working with teenagers. They, pardon my language, they can detect bullshit a mile away, and working with teenagers who've experienced trauma, also experiencing substance use and all of these complexities, they can definitely detect bullshit from a mile away. So showing up as our full authentic selves is critically important. And one of the things that we should challenge ourselves to do is getting genuinely curious about what core beliefs about self, others, and the world may be held by the person that you're working alongside, but also doing that intrinsic work of what core beliefs have I experienced, what implicit biases do I have, and getting really real with ourselves to be able to identify if I'm walking into this space with any kind of implicit bias. And we don't want to assume that we know their story. We want to get curious and be self-aware. And that includes experiences of traumatic stress, that includes experiences related to substance use and how those things co-occur. One of the greatest, I think, honor of the work too is that part of our job, and my job as a mental health clinician, is that I get to unearth and uncover and get to know and share what protective factors also exist, what methods of healing, what support systems exist. there's a number of times that if my person that I am working with enjoys the guitar, we're gonna be talking about that. Like if they like running, we're gonna include that in the safety plan. If they have a strong faith system, yes, let's bring this in. Community is everything. Most healing occurs outside of the therapy room. So we can do some work here, but really what I want to hear is what strengths and supports do you naturally have? What talents do you naturally have? And what an honor to be able to learn those things and bolster those things together. Some ways, not the only ways, you all could give me many more factors to add to this list, but here's some that I focus on well, first and foremost, and this isn't on a slide anywhere, is taking care of ourselves as providers first and foremost, because we can't do any of this without that. So not only from a self-wellness of how do I balance my own wellness to show up with full energy and as much as I can, knowing that I'm human. But also I challenge our organizations to prioritize workforce wellness because we can't expect people to do it if it's not enforced in the organization of how do we take care of the providers because you can't do this without that. So first and foremost, having organizations taking care of the workforce and encouraging balance and radical rest. And then for the workforce of leading with deep listening and cultural humility, we talked about that. Genuineness, full attention, communicating with respect, validating experiences, really listening to learn and not listening to talk. And you can tell that difference, right? Think about times that you've been in an office with a provider and you can feel the speech. You know what I'm talking about? Of like this was rehearsed. They say this all the time. But are they listening? Like, are they listening to what I'm saying? So for us as providers, challenging ourselves to show up with respect and really listening to learn. Educating yourself by asking genuine questions about their life experience, leading with authentic curiosity, remaining as consistent as possible, and transparency, right? We want to model truth telling because there's a lot of secrecy and a lot of shame and hiding that goes along with substance use. And we want to model what it's like to be transparent. So if I am needing to cancel an appointment for a migraine or something, I let them know that. And I apologize for not being able to be there and being able to show up with that human-centered approach and more relational work is so critical because trust is everything. One of the things that we have said a million times so far, and I'm going to continue to say, is that integrated care is best, not only looking at it from addressing the mental health lens, but also the methods of healing. So this may include therapy, it may include medication, it may include both. And that's why a truly integrated team really looks wonderful. Like a interdisciplinary team, if we have psychiatrists, social work, mental health, all of those things, peer support groups, all working together, that's the dream. The family support, peer and or parent support, right? And that would be wonderful. And I know some of you probably work in agencies that do that really, really well too. And I do know, and I'm not naive too, that there's systemic limits to that as well. Really, that community, peer, and family-based approaches are critical. Some common examples of when you're thinking of, because I'm a clinical psychologist, of therapeutic approaches, I have a list of those here that have done work to look at the both and of how do we do TFCBT or ACT or DBT and address substance use at the same time. I think DBT has an entire section in the adults DBT manual that is on substance use. And I think they've done a great job at some of the work of integrating those two things. Obviously, motivational interviewing is foundational to substance use treatment, but it's also good for other forms of treatment too. Thinking of multisystemic therapy or MST, we may even have some MST providers here today, which they do a lot of community-based work, working with families, schools, the youth community out in community to really generalize those skills to real life. You have other lists here, and there's more than this, right? Peer support, also critical of walk. One of the things that we do at the CAST team is we have, and I get the pleasure of co-facilitating our substance use group that is DBT and trauma informed. And the magic of that group is when you see youth start supporting each other and that formation of relationships that are supportive and promoting healthy recovery, like that is the beauty and the magic of when change happens. And I love just being witness to it. I can teach some skills, I can facilitate discussions, I can like bolster connections, but when it actually happens, and those of you who do that group work, it is a beautiful, humbling thing. And I think a lot of healing happens from peer to peer. This is one example of the integrated approach to interventions. You may be familiar with it. It's from the root of this treatment is from Seeking Safety, which is a trauma-informed treatment that is for substance use. And Lisa Suarez created this TSTSA. There's so many acronyms, y'all. I try to explain them. Trauma Systems Therapy for Adolescent Substance Use. And this is a flexible model, right? You can see the phases of treatment on the screen right here, that on the left side, you have the individual, so the child's survival states. And then on the top here, you have the environment level of survival states, just meaning severity of symptoms, right? That it's so flexible, and we need that in integrated treatment, that we start off by saying, okay, what's the safety concern? So if we have a safety concern with the child and a safety concern with the environment, then we have to focus on safety first. If we have some safety concerns and a really helpful and protective environment, we'll of course focus on safety, assess for that, but maybe we can start moving to skills, to regulation-focused skills, because again, we can't take away the way that someone regulates without giving them new ways to regulate those things. And so there's that safety focused. Then you go into skill acquisition, trauma processing, trauma education, and then you go into meaning making and building hope for the future. But you can see where you have to be flexible and assess meeting them where they are in that moment. And it's not linear, right? You may go to skill acquisition and safety comes right back up and you have to shift. And treatment can last 3 to 9 months. So if we're thinking about advocacy work of coverage from insurance, that longer periods of time are needed for this type of treatment. They use methods like MI, psychoed, the interrelation of substance use and traumatic stress symptoms, parent support, family communication. And again, one tool that I use, not on here, and it's not, I don't think it's in the manual somewhere, but it could be, is that timelining. I know the timeline follow back for substance use is a common tool to look at patterns of substance use over time. And I like to overlay that with mental health. It could be trauma, it could be ADHD concerns, it could be other mood and anxiety. So that's one tool. The other thing is the SORC tool, and we'll talk about what that stands for in a second. It's a tool to show up with curiosity. It's really a functional analysis that we acknowledge that everyone's use is different. We want to avoid assumptions and provides information about the context of and reasons for use. And this can be used in collaboration with the youth you're working with, adults too. It can work across the age range, and really, I put it from a lens of trauma, but you could take out trauma, put in depression, put in anxiety, and what you're looking at, and it's jargony. I can acknowledge that, but the stimuli before of what happens before. What increases or decreases the likelihood of substance use, which is the O. The response is the substance use, and then what happens after. So what happens before, what increases or decreases the chance of substance use, and then what happens after the substance use. So you're getting really curious. Think of it as a functional analysis, a behavioral chain in DBT language. You're really getting curious about what are the contributing factors. There's an example here that you all can look at later about trauma. So if you're having a trauma reminder, then the O could be things like I'm having intrusive thoughts. I feel hypervigilant. I can't stay in my own skin. Distress, intolerance. So I use substances, and the result of that could be a decrease in those symptoms, right? But a potential well, I can't say the word exacerbation, there it is, um, in other symptoms like family difficulties or didn't go to work. So laying that out could be something that you all could get curious about together to address some of those root causes, to give more skills around that, or at least more tools to use. That's the framework I use a lot with my teens. If they're not quite sure they want to quit their substance because it does provide that relief. I try to use MI and meet them where they are and say, how about if you have more choices so that you don't have to rely on this only? And I can get some traction there where, yeah, that sounds good. And I'll take what I can get. But like, how about extending those things that you can do in those moments? All right, moving forward really quickly. So, key factors of effective mental health approaches. One of the things I always like to have here is that social ecological model and looking at beyond the individual, that obviously individuals don't exist in bubbles, that we know there's genetic factors and contextual and relational factors that contributes to things like substance use, trauma, and other experiences. So that each layer of relationships, community, society offers an opportunity for understanding, for action, for prevention, for intervention. Thinking about the individual layer, I think of individual one-on-one treatment. Relational layer, I think of peer support groups, family, community, how important that is. Even generally thinking about communities that exist in recovery and how important that is. Of even in the individual work that I do, one of the things that I want to make sure is what is your peer support? What is your recovery network? Let's make sure we're getting you to, if AA works for you, let's do that. And helping to continue that intervention or recovery outside of the therapy room. And then thinking from a public health standpoint, societal prevention and knowledge. And this is from the CDC. You have a link to it here at the bottom. And it's really taking a broader lens from a public health standpoint about advancing health equity, promoting prevention work, which are things like, and I know I'm talking to a room full of people who know this, believe in it, increase access to treatment. We have telehealth, we have other options to reduce barriers, the structural support, housing, transportation, childcare, things that will help receive the treatment that is needed and address root causes and inequities, culturally appropriate practices, support groups and community connections, reducing stigma, acknowledging and working on that valid system mistrust. One of the questions that I ask, because our systems can do so much harm, one of the questions that I ask folks, usually the first time they meet with me, is what is it like being in a place like this with somebody like me? And that gets that unspokenness out of, oh, I don't trust mental health. I and then we can lean into that and understand and addressing those things because we have to start there. And especially with youth, they usually tell me I don't have to really, I don't want to be here. My mom's making me come, or I got to be here for X, Y, and Z reason. Um, Reducing criminalization, linking to care and recovery through multiple venues, not just through our system can be very complicated. Access is critical and quick access is very critical that, we want to, if somebody is brave enough to ask for help in an ideal space, we want to jump on that opportunity as quickly as humanly possible. And sometimes our systems are not made for as quickly as humanly possible. Also, a link here to the principles of a drug addiction treatment I've added a little bit of things here from my own experience as well about components of effective treatment and how we have to look at integrated care, trauma informed, and being and centering our own cultural humility. The best treatment happens through authentic connection, relationship with earned trust, checking ourselves, our own biases. Substance use, difficulties, and addiction is complex. That it impacts brain function and behavior. It is treatable. It's relational work. That no single treatment is appropriate for everyone. We have to meet folks where they are, learn about their community, learn about their families, what natural supports do they have, where are their needs most. I just said this about treatment being readily available. Earlier is better, and it can be life-saving if someone is willing. It's an opportunity that you don't want to lose. We've had the luck to be able to connect with a lot of. There's one person who, and I'm forgetting who he works for, but does a lot of the work. Maybe you all do this work too, of connecting families when they're in crisis and needing treatment right away, and their kiddo is willing to go, that helps families navigate how to get there fast and how to navigate the system. We need more of that. I am blown away with that service, and families are so thankful for that. Effective treatment attends to multiple needs. We've talked about this: medical, psychological, social, job, legal, honoring age, gender, identity, and culture. That it is truly wraparound service needs. Community is so important. Remaining in treatment for an adequate period of time is crucial, that it does take longer. Some research suggesting at least 3 months, but the model we just talked about the integrated care for trauma and substance use, 3 to 9 months. And that is a wide range. It does differ for each person. I wish there was a timeline, but a concrete time, but there just isn't. That things can exacerbate over time. Components of effective treatment, medications are an important element when combined with counseling. We need to continually assess and modify treatment plans to meet changing needs, that it's not a static thing, that it is an ever-changing thing. Integrated treatment is the best. Medical detox by itself has little effect. Detox alone is not enough for long-term recovery. It doesn't need to be voluntary to be effective. That especially, I'm thinking of some of my teens that come in feeling unwilling and powerless of whether or not they want to be there, they're there. And I would totally understand that. And I would feel the same way if I was in their shoes. And at the same time, I have seen that morph into a beautiful relationship and a lot of talking about things that are impacting them. So even if the resistance is there, that we're going to meet them where they are. Am I and rolling with resistance is kind of the name of the game. And I think it shows up over time about how that really does beautifully open up folks to the opportunity to change things in their lives that are difficult. And I love that tool in a number of different approaches. Possible drug use during treatment must be monitored in a supportive, non-punitive way. Lapses can happen. And I think it's one of the things that we try to approach, at least in on the CAST team, with curiosity and bringing to light to address shame that can happen, because the risk of not doing that is hiding in the shame, and that lapse can turn into a full relapse. And so we get curious about, okay, what happened here? Let's do a behavioral chain. I call it a relapse or a lapse chain, to see what happened, what we've learned from it, and how we can support or break that chain differently. Treatment programs should assess for infectious disease, for the other risks that occurs, that co-occurs as well: HIV, AIDS, hepatitis. There's a higher risk for infectious disease, and community is everything, not just for our treatment programs and for our youth, adults, families that are going through this process, but also for us as providers, that we also need that community of each other, other interdisciplinary focuses that are outside of my lens. I'm not a medical provider, but I work alongside some brilliant ones, and I'm so thankful for them. And the best kind of treatment happens when our systems can also be in community and support each other. Okay, I have done so much talking. I think that is it. All right, Jeremy,
Dr.
thank you.
Dr. Tuno, that was amazing. It's really connecting our morning sessions to our afternoon sessions. And I know you're able to sit in on some of Director Crosby's as well, but seeing the pieces come together. And we gave you a tall task of, talking about comorbidities in this space. And we really appreciate the outstanding job that you did there. We had several questions come in. I know that you won't get to all of those. I'm going to try to ask you one or two if you have a few minutes.
Yes,
And then
yes,
if you have additional minutes after, we welcome you to type responses in. If you could just stay in the panelist space, and then we'll go to our lunch break.
for sure.
We had a question come in about resources for programs, any resources for programs/initiatives that are working to close the disparity gap amongst Alaska Native and Indigenous adolescent populations.
Actually, yeah. So at the NCTS, oh, sorry, I meant to click on something else. On the, if you go to nctsn.org, and I don't want to highlight just one of them, but there's a number of organizations and resources from our tribal youth leader networks that are doing a lot in suicide prevention work, that are using things like land-based healing and from a truly cultural humility and culture or community-led framework of those most impacted leading those efforts. So taking some of the suicide prevention language and using it that applies to them in the ways that they focus from their culture of healing. So I would go to nctsn.org, look at the Indigenous and tribal leader work that is being done there, and you can absolutely find some really interesting things.
That's really helpful. NCTSN is a great resource for a lot of adolescent topics. I think we'll wrap up with a couple of connected questions on Kratom. I don't know what your experience is in the field with that, but there's a couple questions about it, and they're asking, are you seeing it in terms of misuse? And then why are patients using it? What are the benefits and harms?
Yeah, I am seeing it, unfortunately. So I know, and this is all from my clinical experience. I know that it is sold in smoke shops. It can also be sold in, uh, I think, like vitamin stores too. I'm not, don't quote me on that, but I know youth can get it legally. And it's made from the leaves of some plants in Asia, I believe. And so if you use it, you can make tea from it, things like that. And if you use it in high quantities, it does give an effect, a disorienting effect. The thing I've also seen anecdotally and clinically is that it also gives really um, s- difficult side effects too. A lot of GI issues that I've seen that go along with that. So I'm still learning about the effects of kratom and the side effects with it. It's so new to me, and I haven't seen a lot of research about long-term effects. I don't know if anybody else has, would be super interested in learning more about that too. But I have seen more and more kratom use that folks can just go and get. It's everywhere. But yeah, it does provide some sort of high if used in higher quantities.
Thanks for taking that one on. We've had some speakers in recent times at some of our more medical focused conferences talk a little bit about that, but it is a really hot topic, and we appreciate you entertaining that question as well.